Hi, welcome everyone to yet another episode of Guideline Review of the Week. This week I'm discussing a topic that is very commonly found in our pregnancies, in our pregnant women. A lot of our women have some history of some seizure that they had. In fact, a lot of patients even give history of the febrile seizures that they have been told about during their own childhood while they were infants themselves. So, how much of such a history is significant? How much should it have any weightage or any leverage during pregnancy? How and when should we be giving all these anti-epileptic drugs? And what are the effects of these drugs? What are the effects of epilepsy as a whole phenomena on pregnancy? And how does pregnancy affect these events? All of this I'm going to be covering today, and I hope this is a good session for you all. There are a lot of things, there are a lot of topics that a lot of people are not really clear about, a few concepts that they are not sure about, and I hope this session will clear all of them for you. I believe it might be a little longer than our usual sessions. It's a longish kind of a guideline, so I hope you all stay with me till the end. So, welcome and let's go. So, today's guideline is again taken from my probably something that has become my favorite by now. It is the Green Top guideline that has been taken from Royal College of Obstetricians and Gynecologists. So, when I talk of epilepsy in pregnancy, this is a June 2016 guideline and it is quite relevant even today, 8 years down the line. It is followed by several institutions and these are few of those. उसमें से nice तो तुम लोग सब लोग ने पढ़ा ही होगा. So, for whom does this guideline concern? The first question. So, this guideline concerns WWE. It is a word that you shall read quite often in this guideline. It is women with epilepsy. It is for all women who have had any history of epilepsy. So, during their pre-conception period, when they come to you for pre-conception counseling, for women who have gotten pregnant and have a history or are known cases of epilepsy, and intrapartum when they go in labor, what are the changes, what are the instructions that we have to follow, and in the postpartum period. Intrapartum and the postpartum period are two such periods in which the seizure threshold decreases and there is an increased chance of epilepsy. This is a notion. Is this true or not is also something that we shall learn eventually in this session today. So, why is it significant? Talking about UK, I've not given Indian data right now, but a lot of this is very similar to what you find in our country. It has a prevalence, epilepsy in pregnancy has a prevalence of 0.5 to 1%. So almost 1 in 200 to 1 in 100 women. In fact, I believe it is a lot more common in India. I would say almost 1 in 70 or 80 women have some history of epilepsy. So a lot of these women, the women that they are talking about here, are the ones who are currently having epilepsy, are the ones who have had a recent bout or have regular recent bouts, who give history of regular recent bouts of epilepsy. So 1 in 100 to 1 in 200 is the um, is the prevalence. An estimated of 2,500 infants are born in the UK. So in India, obviously, UK's population is hardly as much as of Mumbai. So for the entirety of a country, the numbers are going to be very high for the number of infants that are born to these mothers. Do infants face the brunt of epilepsy that their mothers carry? Definitely they do. What we shall be learning it eventually. Of course, it is a lot more than what we have learned until now about teratogenicity, congenital malformations. There's a lot more to it. So what else we shall learn eventually today. So it is significant from the first point of being that it is so common. Apart from that, the risk of major congenital malformations are increased in women who are taking these drugs. So, major congenital malformations. By major congenital malformations, I intend to say two major things. The first one is सबसे important neural tube defect, and the second one is cardiac defects. बट उसमें से जो न्यूरल ट्यूब डिफेक्ट है वो काफी सिग्निफिकेंट, इट इज वेरी वेरी सिग्निफिकेंट. वी शैल लर्न हाउ एंड विच ड्रग्स कॉज इट इसके बाद में. So the risks of these malformations are significantly increased in the fetuses in women who are having epilepsy and are taking anti-epileptic drugs. So another short form, AED, you shall read multiple times in the document. It is anti-epileptic drug. WWE was women with epilepsy. Apart from that, there are women who have a very high risk. There are women, I mean, there are nowadays a lot of women are educated about the condition. They read on Google, they read a lot on the internet about the drugs that they are consuming prior to conception. So, a lot of women, without taking any consultation of a neurologist or an obstetrician, stop taking these drugs prior to pregnancy by assuming that they have not had an episode of epilepsy for a few months or maybe a few years, and they stop it themselves. And this is the biggest risk factor for SUDEP. Now, SUDEP is something more, one more acronym. SUDEP is sudden unexpected death in epilepsy. So basically, sudden death because of epilepsy or during a bout of epilepsy. So a lot of women, because of their discontinuation or reduction in the dose of AEDs, increases the female's risk of seizures and death because of seizures. So this is a very significant factor. Seizure deterioration and anti-epileptic exposure in pregnancy have an enormous impact on the life of mother. तुम लोग अगर बंद करोगे या फिर कम करोगे, the female will have a seizure episode. तुम लोग अगर बढ़ाओगे dose, so that you can compensate for the pregnancy में excretion जो बढ़ता है drugs का through excessive renal blood flow, GFR बढ़ता है, so the excretion is increased. So because the excretion is increased, the half-life of these drugs decreases. So because of this factor, you tend to increase. You think that increasing the dose will not lead to an increased threshold frequency, but no, that will eventually lead to malformations in the fetus. So कहीं पे भी जाओ, कम करोगे तो सीजर आएगा, ज्यादा करोगे तो fetus पे फर्क पड़ेगा. So there's a very narrow range. There's a window in which you have to operate while giving these drugs to your patients. So how do you diagnose? A very basic thing, a very physician kind of a thing. How do you diagnose epilepsy? So it has to be made by a medical practitioner who is an expert in epilepsy. Of course, it's a very straightforward diagnosis, but the cause of epilepsy is what requires a neurological consultation, a consultation from or with a physician who can tell us what is the probable cause of this epilepsy. Is it because of some space occupying lesion or is it some functional lesion? So that is something that shall be helped. We shall be helped by taking some assistance, some consultation with a neurologist or a physician. So women with a history of epilepsy who are not considered to have high risk of unprovoked seizures can be managed as low risk women. So basically women who have no significant history of unprovoked seizures, they can be considered like any other woman and they can be considered in a pregnancy that is a low risk pregnancy. So the first thing that we should be aware is that epilepsies are a group of heterogeneous disorders of brain diseases with the common symptom of seizure. So basically seizure is just a symptom. Seizure is not the problem. The problem is something that is in the brain. There is some disorder, there is some disease in the brain that we have to know that is causing seizure. Seizure is like a symptom. It is like jaundice. Jaundice is a manifestation of some liver disorder like hepatitis, and we should know what is the cause of that seizure. So that is very important. So women who have been seizure free for the last 10 years, no seizures for the last 10 years, and for the last 5 years without any anti-epileptics, and those with a childhood epilepsy syndrome who have reached adulthood seizure and treatment free interval are considered to be no longer having epilepsy. So you are said to be epilepsy free if you have had no seizures in the last 10 years, of which the recent most 5 years have to be without the consumption of any anti-epileptic drug. Now, this is something that I have seen a bit differently in my practice. There are a few physicians who advise that even 2 years of epilepsy-free interval is often considered to mention that a patient can be considered as epilepsy free, but it differs. But the official definitions that the Royal College of Even Physicians follow is that 10 years without a seizure, of which the recent most 5 years have to be with seizure free without even taking any drugs. So what are the various types of seizures that we can have? The most common is GTCS, tonic-clonic seizures, the exact one that we get in eclampsia as well. So in which there is dramatic event with stiffening, then bilateral jerking and post-seizure confusion and sleepiness. So basically, first of all, there's a tonic phase wherein the body is tightly clenched, the body is tight. After that, there is a clonic phase wherein the body is jerking like this. and then after that there is no such body activity, and the patient has post-ictal or post seizure confusion or altered sensorium phase. So basically the patient doesn't understand, realize कि आजू बाजू में क्या है. The patient is completely altered. There is no distinguishing between what is right, what is wrong. So there is a post-ictal phase also that follows. So this is a very classical GTCS. This is what we see even in our patients who get eclampsia. So, what is the effect of this on the mother and baby? How is it significant? I mean, a female can have eclampsia का ऐसे GTCS, or she can have GTCS because of some other lesion in her brain. इससे बेबी पे और मदर पे क्या फर्क पड़ेगा? सबसे पहले तो इसके वजह से सडन लॉस ऑफ कॉन्शियसनेस होता है, which leads to an uncontrolled fall without a warning. So a female might just fall onto the ground when she gets this episode. Now this will lead to, obviously, if she falls on her abdomen, this will lead to a massive trauma. If she's in a second or third trimester, or maybe even in third trimester, it can lead to rupture of membranes. It can lead to abruptio placentae, traumatic abruptio placentae. This can lead to preterm delivery. So definitely, also when there is a tonic phase, when there is impaired respiration, there is a phase of apnea wherein the person is not breathing when he's in that tonic phase, when she's in that tonic phase. During that time, the body's SpO2 levels, that the oxygen levels might fall down. Because of this falling down, the baby will receive less oxygen. This will lead to periods of hypoxia for the baby. This can have a deleterious effect on the baby. If there are multiple such episodes, multiple hypoxic episodes, there is going to be impairment of fetal growth. So there is going to be IUGR, or fetal growth restriction. Also, there can be possibility of IUFD if there is prolonged hypoxia, as happens in the case of status epilepticus. Status epilepticus is basically prolonged seizure which is not controlled, or there is no regaining of consciousness between two seizure episodes. So this seizure type is associated with the highest possible risk of SUDEP. SUDEP is sudden death because of seizure episode. The other ones, not so dangerous ones, are absent seizures. Absent seizures are basically, there are brief blank spells wherein the patient is just staring into the air, thin air, does nothing, वो बस शांति से ऐसे ही बैठा रहता है, seizure आके भी जाता है. The patient though is unresponsive, we might call out the patient, but the patient will not respond. After which there is no post-ictal phase, the patient recovers immediately. There is rapid recovery. So इसमें बेबी और मदर पे प्रॉब्लम क्या आ सकता है? द इफेक्ट्स मीडिएटेड थ्रू ब्रीफ लॉस ऑफ अवेयरनेस are modest. They are not significant. Although the problem is that if these absent seizures worsen, the female might have a tonic-clonic seizure. So she might have a GTCS if these absent seizures continue for a long time. Then there are not so significant one, myoclonic epilepsy, wherein there are body jerky movements of a group of muscles especially. So myoclonic jerks, basically muscles have a jerking movement, something that happens in a clonic phase, but यहाँ पे myoclonic में there's a specific group of muscles like flexors or extensors जो contract करते हैं, and there the female has continuous jerks that follow. These often occur because frequently after sleep deprivation. So sleep deprivation is in fact one of the highest factors for even GTCS. And in the periods soon after waking up or when tired. So basically tiredness, sleep deprivation are the type of seizure जिसमें ऐसे type के myoclonic jerks और bodily movements आ सकते हैं. These sudden jerks might, like leg के muscles का अगर हो गया, this might lead to fall and dropping of objects including the baby. So if the mother is having these myoclonic jerks and she is a postpartum female who's holding the baby, because of these jerks she might end up dropping the baby, or if she's antenatal she might herself fall on the abdomen and can have all those things that I just mentioned in GTCS. Apart from that, focal seizures are basically एक कोई तो area है, there's a focus in the brain which is having there are specific regions and networks in the brain that are affected, जिसके वजह से उसी region के parts affect होंगे, only those regions will be affected. The problem though is that these focal seizures might eventually become secondary generalization, which means that that one particular focus will eventually spread over the entire brain, and it will eventually lead to a generalized tonic-clonic seizure, a GTCS kind of a seizure. So impairment of consciousness, अगर एक कोई तो एरिया का ऐसे हो गया and the person might just fall down leading to fracture, dental or head injury, electrocution or burns, like the patient will have sudden loss of that area, that part ka movement, and the patient might fall, something that is very similar to myoclonic jerks. So these are the four main types of seizures. The epilepsy episode is the one that we need to know. Most importantly is GTCS. So what are other conditions that need to be considered? There are a few conditions that they believe that should be considered. एज अ डिफरेंशियल डायग्नोसिस ऑफ एपिलेप्टिक सीजर सबसे बड़ा अपने लिए तो जो है इट इज सेड टू बी नथिंग मोर देन इक्लैम्शिया. सो इक्लैम्शिया इज अ वेरी इंपॉर्टेंट रिस्क फैक्टर. So history of preeclampsia is very important, and in fact they do say that in second half of pregnancy, if the female has a seizure, it is eclampsia unless proven otherwise. It's an old dictum in obstetrics wherein any seizure in second and third trimester is an eclampsia without, if I mean it is an eclampsia if there is no other proof, or it is until proven otherwise. So basically eclampsia until proven otherwise यानी इसको eclampsia ही name करो, treat it with magnesium sulfate, manage her as a patient of eclampsia, think of terminating her until you have a definitive diagnosis that it was not eclampsia. हाउ डू आई नो कि ये इक्लैम्शिया नहीं है? आई हैव इमेजिंग मोडालिटी. सो एमआरआई ब्रेन कर सकता हूं मैं. अगर मैं एमआरआई करूंगा और मुझे फीचर्स ऑफ प्रेस दिखते हैं, दैट इज पोस्टीरियर रिवर्सिबल एनकेफेलोपैथी सिंड्रोम, इट इज वेरी क्लासिकली सीन इन वुमेन विद इक्लैम्शिया. सो मुझे वो पता चलेगा. अगर वो नहीं है एंड देयर इज सम फोकल स्पेस ऑक्यूपाइंग लीजन, समथिंग लाइक अ ट्यूबरक्यूलोमा or something like hemorrhagic stroke जैसा कोई पे spot है, so there can be several other lesions. So I can do a CT scan. Oh yes, I can also do a CT scan. It is cheaper and is not resource intensive. So I can do a CT scan because a single exposure of the brain will not lead to any teratogenic effects on the fetus. Of course, you can also put a lead apron and can protect the fetus if you're doing an MRI of the a CT scan of the brain. But MRI is a better modality, एंड उसमें तुम लोग को वीनोग्राम भी करना है. एमआरआई वीनोग्राम करना जरूरी है क्योंकि काफी बार द सोर्स ऑफ सीजर इज अ सेंट्रल वीनस साइनस थ्रोम्बोसिस. So there are cerebral venous sinuses. There are collections of blood within veins that are present in your brain. एंड उसमें क्लॉटिंग की वजह से हाइपरकोएगुलेबिलिटी ऑफ प्रेगनेंसी जो होता है, बेसिकली प्रेगनेंसी में कोएगुलेशन फैक्टर्स का प्रोडक्शन बढ़ता है. सो बिकॉज ऑफ दिस हाइपरकोएगुलेबिलिटी देयर कैन बी क्लॉट्स दैट आर फॉर्म्ड इन दीज सेरेब्रल साइनसेस, वीनस साइनसेस. दिस कैन बी वन ऑफ द रीजंस व्हाई द फीमेल हैज हैड अ सीजर. सो डू एन एमआरआई विद वीनोग्राम. सो वीनस फेज या फिर वीनोग्राम उसको मैं बोलूंगा. Do it with a venogram so that you also see the venous structures in your brain. If there is any doubt whether the seizure is secondary to epilepsy or eclampsia, give magnesium sulfate, which is the drug of choice. It is a very safe drug वैसे देखेंगे तो, and it should be administered until a definitive diagnosis is made because there is no nuksan, there is no loss, and it's a very safe drug. We have already discussed in one of the OBGYN nuggets of the 5 receptors, of the 5 actions of magnesium sulfate. A very safe drug, you can easily give it. बहुत कम उसके side effects से है उसके. We have all read about pulmonary edema, depressed knee jerks, but they are not that common. And यहाँ पे maternal benefit पहले देखो. You can give this patient magnesium sulfate and manage her like eclampsia. Think of terminating her until you have some diagnosis that shows that no, it is not eclampsia. What are these other differentials then? एक तो हमने already बात किया cerebral venous sinus thrombosis, posterior reversible leukoencephalopathy syndrome, which is something parallel to eclampsia. ल्यूकोएन्केफेलोपैथी या एन्केफेलोपैथी सिंड्रोम भी बोल सकते हो. स्पेस ऑक्यूपाइंग लीजन्स लाइक थिंग्स लाइक मेनिंजियोमा या फिर ट्यूबरक्यूलोमा, एनी मास, एनी ट्यूमर और एनीथिंग दैट हैज ग्रोन इन योर ब्रेन, सो अ स्पेस ऑक्यूपाइंग लीजन. And reversal cerebral vasoconstriction syndrome. There is vasoconstriction of various vessels that leads to periods of ischemia to the cerebral cortex that leads to seizure episodes. Other episodes that can be something that relatives tell you कि सर ये शायद उसको अकड़ी आके गया है, मिर्गी आके गया है, but you ask them properly, or if it has happened in front of you, then it can probably just be a syncope attack. An attack of syncope. Syncope is a short period of unconsciousness because of loss of oxygen or loss of blood supply to the brain. So that can be associated because of a cardiac arrhythmia or an aortic stenosis. Arrhythmia or stenosis की वजह से cardiac output would be reduced, और carotid sinus sensitivity जिसकी वजह से वेगस का जो एक्टिविटी वो बढ़ेगा. वेगस will lead to depression of cardiac activity and the blood supply to the brain will be reduced, जिसके वजह से because of transient ischemia, it is not permanent, it is not causing complete ischemic, something that happens in ischemic stroke. यहाँ पे stroke नहीं हो रहा है, बस थोड़े से टाइम के लिए the blood supply or the oxygenation to the brain is reduced. It will recover, it is reversible, but for that period of time the female had syncope or a period of epilepsy. Apart from that, Electrolytes, I mean dyselectrolytemia, which includes hypoglycemia, reduction in the blood glucose levels, hyponatremia, hypocalcemia, hypomagnesemia. All these electrolytes have to be checked whenever a female has an epilepsy to confirm that it was not because of some electrolyte imbalance. Apart from that, Addisonian crisis can also be ruled out, has to be ruled out before confirming that it is eclampsia. So treat her as eclampsia, give her magnesium sulfate, think of termination, give her steroid cover, and then simultaneously start working her up. Don't wait for all your reports to come in before you start the treatment for eclampsia for her. Hence, it is eclampsia unless proven otherwise in the second half of pregnancy. What is the pre-pregnancy counseling and management that I should be doing for these women? What is the counseling that I do for this? So, women who are planning their pregnancy should have a clinician or a neurologist who is good enough in the management of epilepsy, should be taking a decision for her. Women should be informed that the risk of congenital abnormalities is dependent on the type, number, and dose of AEDs. So basically, कौन सा drug ले रहे हो? Which drug are you taking? What is the dose that you are taking it in? And I mean, these are the two main factors: which drug and which dose, and what dose are you taking it? So, for a comparison, in women who had epilepsy but had not taken anti-epilepsy, the incidence of congenital malformations is similar. So basically, यहाँ पे ये बताया जा रहा है that the risk of malformations is not increased in women who only have epilepsy but are not consuming any drugs. It is increased only in women जो लोग drugs ये ले रहे हैं. Hence, the second line, in women who are taking drugs, the risk of malformations to the fetus are dependent on the type, number, and dose of AEDs. Among the anti-epileptic drugs, lamotrigine, carbamazepine, these in monotherapy at low doses have the lowest risk of congenital malformation. So we have two safest drugs. एक तो है lamotrigine and the other one is low dose carbamazepine. एंड रिमेंबर यहाँ पे उन्होंने मेंशन किया है मोनोथेरेपी, नॉट कंबाइनिंग देम. कंबाइन करने से उनका फिर से ज्यादा होने वाला है. इट विल एड द टेराटोजेनिसिटी ऑफ बोथ द ड्रग्स. The most common major congenital malformations that are associated with anti-epileptic drugs, we all know that it is neural tube defect. There are also congenital heart diseases, urinary tract and skeletal abnormalities, and cleft palate. Now, sodium valproate is one that is associated with neural tube defects, facial cleft, and hypospadiasis. Hypospadiasis is basically the opening of the urethra, external urethral meatus below the penis. So, hypospadiasis is common. Phenobarbital is a barbiturate, and phenytoin leads to fetal hydatine syndrome. Fetal hydatine syndrome. फीटल हाइड्रोटाइन सिंड्रोम का एक नेमोनिक है जिसमें दे टॉक अबाउट PHEN, उसका नेमोनिक है. सो इन P देयर इज पैलेट, सो देयर इज क्लेफ्ट लिप एंड क्लेफ्ट पैलेट. H से आता है देयर इज स्मॉल हेड, दैट इज माइक्रोकेफेली. देयर इज हर्सुटिज्म. देयर इज हाइपोप्लास्टिक फेस, मतलब उनका जो फेस के फीचर्स है दे आर वेरी स्मॉल. ऑल्सो देयर आर गोइंग टू बी हार्ट डिफेक्ट्स. And from E, there is going to be embryopathy. And lastly, from N, it is going to have neurological defects. So PHEN is the short form for fetal hydatine syndrome that occurs because of the consumption of phenytoin. Whereas with sodium valproate, which is a good anti-epileptic drug, but a very bad teratogen, it leads to neural tube defects in general. Neural tube defects are basically spina bifida, meningoencephalocele और sacral agenesis. ये सब जो neural tube defects है वो हो सकते हैं because of sodium valproate. So the best two drugs are going to be, green में लिखता हूँ मैं यहाँ पे, the best two drugs are going to be lamotrigine and carbamazepine, but in low doses. There is also a third drug that we use, but जिसका अभी तक sure नहीं efficacy, but from whatever experiences that we have, it is said to be a safe drug, levetiracetam. यहाँ पे मैं लिख रहा हूँ low dose में. Whereas the bad ones are the ones that I'm going to be writing in red: valproate or valproic acid, phenytoin, topiramate, gabapentin, pregabalin. All these drugs not safe, barbiturates. Don't use them. Phenobarbital उसका एग्जाम्पल है. So the risk is highest for women taking, the risk of congenital malformations is the highest for women taking sodium valproate and polytherapy. So multiple drugs जो ले रहे हैं उनमें the risk is very high in comparison to women who are taking monotherapy or not taking sodium valproate. Whereas the lowest risks were found in women who are taking less than 300 mg of lamotrigine per day and less than 400 mg of carbamazepine per day. So lamotrigine and carbamazepine has to be consumed. The safest two drugs, the dose is less than 300 milligram of lamotrigine and less than 400 milligram of carbamazepine. Also, the rates were lower in the levetiracetam monotherapy. So it is something under study, but it is known to be a safe drug. Whereas for all these drugs that are given over here, I'm marking them with red. There is not enough evidence to suggest कि वो safe है या नहीं है. So इसमें एक तो आता है gabapentin जो बहुत important है, एक lacosamide है, oxcarbamazepine है, which is an OS, which is a isomer of S isomer of carbamazepine. Pregabalin and topiramate are few of the common anti-epileptic drugs that are not yet known to be safe or not in pregnancy. So use करना है तो lamotrigine दे दो, carbamazepine दे दो या फिर levetiracetam दे दो. Also, the risks of malformations were increased if the patient was already taking anti-epileptic drug and the baby, I mean the pregnant female had a previous child with a major malformation, with a major congenital malformation. So the risks were quite high in women who have already had a child with a disorder. So drugs जिसको पहले भी एक बेबी हुआ है उसके अगले प्रेगनेंसी में the risk is significantly increased. Next, what are the long-term neurodevelopmental outcomes to the exposure of AEDs and the maternal seizure in infant born to WWE? So मैंने ये अभी जो बताया they were all immediate outcomes. मतलब बेबी ने उन्होंने खाया and बेबी में दिख गया इफेक्ट, हाइपोप्लास्टिक बोन्स हो या फिर हाइपोप्लास्टिक फेस हो, cleft lip, cleft palate, neural tube defects immediately in utero हो गया है. What are the long-term effects after the baby is born, after 3 years, 6 years, 10 years down the line? So based on limited evidence, again, carbamazepine and lamotrigine do not appear to affect any neurodevelopment. So again, these are two long-term इसमें भी ये safe है, short-term में भी safe है. Little evidence for levetiracetam and phenytoin long-term इसमें. So when we talk of it, children exposed to sodium valproate in utero had a significantly lower developmental quotient. So the development, the neurodevelopmental जो neurodevelopment होता है, जो neurodevelopmental milestones होते हैं, they are slowed, they are lower than in babies who had not consumed sodium valproate or had taken the safer drug. So sodium valproate has short-term neural tube defects as well as long-term neurodevelopmental delay, delayed milestones, low IQ. So the intelligence quotient, that is IQ, the verbal IQ, the way they speak, the performance in their classrooms were lower in children exposed to sodium valproate. So obviously this says that sodium valproate is a big no during pregnancy. Try to switch it prior to conception. There's a rule that you do not change anti-epileptic drugs in pregnancy because changing that can precipitate an episode of seizure. You can do it prior to conception. So the IQ, the way they performed, the way they spoke, everything was poorer in women who had consumed sodium valproate during their pregnancy. So long-term हिसाब से भी sodium valproate is not safe, whereas exposure to carbamazepine had no effect on IQ, verbal IQ, and performance. So carbamazepine less than 400 milligram per day, very safe. Children exposed to sodium valproate had a lower IQ. Again, the same thing at 6 years of age. So even 6 years after their delivery, after they were born, after they are not having any contact with sodium valproate, they have had a lower IQ in comparison to the ones who had taken carbamazepine, lamotrigine, phenytoin as well to an extent. Phenytoin will have short-term effects, but long-term effects uske nahi hai, which is a good thing about phenytoin. So if a female is taking phenytoin and she has conceived already, I would just do a good malformation scan and see if the baby is having any defects. Long-term to kuch nahi hai. Apart from that, they also performed very poorly on measures of verbal and memory ability. So they had poor memory skills and they had also poor executive function. मतलब काम करके दिखाना, that was also not good. Hence, The non-verbal ability, memory, and executive functions are very poor in patients who are consuming valproate. So finally, sodium valproate is a big no. It also has an increased chance of childhood autism. So autism के भी chances बढ़ते हैं. So overall, sodium valproate is a strict, a big, absolute contraindication during pregnancy. लेना है तो lamotrigine लो, carbamazepine लो या फिर चाहिए तो थर्ड ड्रग एक लेवेटिराcetam ले लो. A bit of a break. You would see that my shirt has been changed. I would like to show that the lecture is continuing from where I've left off in the last paragraph. But no, थोड़ा change हुआ है. It's another day. I had some emergency. I had to cut short my lecture, this session in between. So yeah, continuing from the part where we had just left off and I changed my shirt in between. So how do I prevent all these congenital anomalies that can occur in women who are taking all these drugs? We have already discussed that the epilepsy is not the problem here. The problem here are the drugs that she is taking. Women with epilepsy will still have babies who don't have any congenital abnormalities. But the problem lies in those women who are taking anti-epileptic drugs. We have also discussed that अगर मैं dose बढ़ाऊंगा क्योंकि excretion बढ़ रहा है, the half life is decreasing, so I have to increase the dose probably. But if I'm increasing the dose, the congenital malformations का risk भी बढ़ जाता है. किसमें ज्यादा है? Sodium valproate. We have read it. If I reduce the dose so that I don't get those malformations, then I risk precipitation of an attack of epilepsy. She might end up getting an epilepsy when she has not had it for the last 1 year or two, probably. So she will have an increased frequency of having epilepsy if she's already having in the recent past. So I have to manage or I have to get that balance in order so that I don't have any problem with increasing the dose or needing to decrease it. So how do I find that midway? The midway is given to me by a drug, a very common, a very cheap, but a very effective drug called as folic acid. Folic acid acts in a great way to prevent these neural tube defects, especially in patients who are consuming sodium valproate. Now you have to understand that sodium valproate might be a very bad teratogen. It causes bad abnormalities, neural tube defects, but it's a very effective one. Especially if a female who has been resistant to a lot of drugs, anti-epileptic drugs before, she will achieve remission on sodium valproate, that is valproic acid. And hence, if a female has already achieved remission on it, despite, because she already was refractory to other drugs, then it's not wise enough to stop that drug, especially if she has already conceived. So in that case, especially if she has already conceived, I will start her on 5 milligram of folic acid. Now, the usual dose that we give for non-high risk women is zero point 0.4 to zero point 0.5 milligram. The way it is available in the market, we give it once a day. But for patients who have a high risk of neural tube defects, like the patients who have history of having had earlier babies with neural tube defects, or babies who have a risk in current pregnancy because they are consuming some anti-epileptic drug, especially valproate, which has high risk of neural tube defects. So all these women have to be advised to take 5 milligram of folic acid per day at least 3 months prior to conception, and to continue the intake at least until the end of first trimester to reduce the incidence of major congenital abnormalities. Technically, we continue it throughout the gestation. That does not have any side effects. It is in fact a good thing to have folic acid, क्योंकि उससे anemia भी anemia भी होने से बच जाता है. But the bare minimum that she should be consuming it is 3 months prior to conception till 3 months after conception. That is the end of first trimester. टेक्निकली एटलीस्ट अंटिल 15 वीक्स, क्योंकि 15 वीक्स तक ऑर्गेनोजेनेसिस चलता रहता है. प्री प्रेगनेंसी फोलिक एसिड 5 milligram is helpful in reducing the risk of anti-epileptic drug related cognitive defects as well. So cognitive defects, which were basically the long-term defects, so not just neural tube defects but also the post delivery 3-4 साल की उम्र में, we had discussed that these babies often have cognition के defects. They have problems with memory skills, learning abilities, all these intellectual abilities के जो dysfunction होता है, जो lack of ability होता है, that is also reduced. So a short term as well as long term benefit is afforded by taking 5 mg of folic acid. Also goes without saying that the lowest possible effective dose of anti-epileptic drug has to be used. Don't try to increase the dose, and also avoid polytherapy, that is giving multiple drugs. So give monotherapy. Exposure to sodium valproate and other anti-epileptic polytherapy. So sodium valproate and combination of other anti-epileptic drugs has to be minimized by changing the medication prior to conception. If you do that after she conceives, then there is a risk that she will have an episode of seizure. So do it prior to her conception. So यहाँ पे उन्होंने सेम चीजें नीचे एक्सप्लेनेशन में दी है that studies have evaluated the effect of folic acid, and it has shown that low folate levels or no supplementation has a very high chance of major congenital malformation. So you have to take it. Apart from that, these children were having higher mean IQ when they were taking pre-conceptional folic acid. So it is important that she conceives it 3 months prior to conception and not only after conception, because these babies have a long-term effect of the same. So given the positive and potential benefits, it has to be started at least 3 months prior to conception, a point that I've been emphasizing on in this topic multiple times. Apart from that, same thing, that sodium valproate and polytherapy has to be avoided. The aim is to avoid it as much as possible. And if though there is a risk of maternal seizure deterioration and a risk of sudden death because of seizure episode, then you do not change it and you can just continue sodium valproate and AED polytherapy, but that is in exceptional circumstances. नाउ द अदर वे अराउंड, अभी हमने बात किया कि ड्रग्स एंड एपिलेप्सी का प्रेगनेंसी पे क्या प्रॉब्लम आता है. नाउ व्हाट इज द इफेक्ट ऑफ प्रेगनेंसी ऑन एपिलेप्सी? सो women should be informed that almost 66% of the women will not have any seizure deterioration. मतलब अभी अगर 2-3 साल में एक बार आता है तो प्रेगनेंसी में भी वैसे ही रहेगा. The risk won't be increased for 66% of the women, whereas the remaining women, 33%, will probably have an increased risk of having an episode during pregnancy. Now, what is the reason that a lot of women don't have any seizure during pregnancy? Is that during pregnancy, the hormone that increases is progesterone. Now, progesterone is said to have a good effect on epilepsy. It increases the threshold of our brain to epilepsy. So basically, by increasing the threshold, I mean the patient has a lower chance of getting an epilepsy. So progesterone is a very helpful hormone. It is a very helpful drug. In fact, a side thing, we often give DMPA to patients with sickle cell disease as well as patients with history of epilepsy because it helps to maintain a high seizure threshold level. So DMPA or progesterone pills, especially DMPA. So a majority of women will not experience any seizure during pregnancy. Obviously, I'm not talking about eclampsia over here. I'm talking about normal epilepsy. Eclampsia ka chances are independent of all these risk factors. The seizure-free duration prior to conception is the most important assessing factor. So women who are at least 9 months to 1 year, let's just assume a year prior to conception, they were seizure-free. Almost 90% of these women won't have any seizure during pregnancy. So the biggest important factor over here is to be considered is कितने महीनों से कितने सालों से उसको नहीं हुआ है seizure. So if she has had the last 1 year without any seizure, then almost 90% of there's a chance that she won't have it even during pregnancy. How should I be monitoring the taking of anti-epileptic drug to avoid worsening of seizures? And is dose escalation better than expected management? So the same dilemma that we had earlier, that pregnancy में there is an increased यहाँ पे the pharmacokinetics are changed because the absorption, metabolism and excretion, all of these change. So the levels of all these anti-epileptic drugs are known to fall during pregnancy. So basically, the half-life decreases in the body of all these anti-epileptic drugs the moment the female gets pregnant. Absorption is impaired. Also, the excretion is increased. So in this case, should I step up the dose or should I just wait and watch? So they have postulated that the falling drug levels may contribute to worsening seizures, leading to prophylactic increasing in lamotrigine dosing during pregnancy. Whereas a few people have said that there is no evident benefit that is afforded if I'm going to increase the dose. So the current practice is regular therapeutic drug monitoring, TDM. So in this मैं serum levels monitor करता हूँ, या फिर if I don't have the facility or it is too expensive to monitor the drug, then I do the clinical features to adjust the dose. So clinical features यानी मैं पेशेंट को पूछता हूँ कितने टाइम से नहीं हुआ है, अगर ये प्रेगनेंसी में हुआ तो ही मैं स्टेप अप करूंगा, अदरवाइज आई विल हैव अ वेट एंड वॉच मैनेजमेंट. इफ आई हैव द एबिलिटी टू टेस्ट द डोज लेवल इन द बॉडी, देन आई विल डू थेरेप्यूटिक ड्रग मॉनिटरिंग. So what are the adverse effects of AEDs in pregnancy on the mother and how they can be managed? Now we have spoken about the fetus. The fetus has all those malformations and cognitive defects, neurodevelopmental delay. What is the effect of the drug on mother? So these mothers are known to develop depression, especially postpartum depression. Anxiety is increased, and neuropsychiatric symptoms, psychotic symptoms can be increased, wherein they can have hysteria, they can have neurotic episodes. So ये सब उनका बढ़ने का chances काफी ज्यादा है. They also have a potential to affect maternal cognition when higher doses are taken. So maternal cognition यानी डे टू डे स्किल्स का परफॉर्मेंस, रिमेम्बरिंग, मेमोरी स्किल्स, ये सब जो है, द एग्जीक्यूशन ऑफ टास्क, ऑल दीज थिंग्स कैन बी स्लोड डाउन और दे कैन बी फॉरगेटफुल. सो ऑल दीज प्रॉब्लम्स कैन अकर एट हायर डोसेस. Psychosocial problems, low esteem, fear of having seizures may have a negative impact. So they might start feeling that I might just go out and I might have an episode of seizure and it will be very socially embarrassing. I may not even have someone with me to help me. So they start avoiding contact with people. They stop going out. So it can have a psychosocial, very cultural aspect to it कि वो लोग अपना contact avoid करने लगेंगे लोगों से, जिसके वजह से they might have eventual depression. They might eventually develop major depressive disorder. So in this case, you don't need to start her on any antipsychotic medication until there are severe enough symptoms. You just refer her to a psychiatrist. They will take care of this. But yes, higher doses may anti-epileptic drugs can have an effect on the mother herself. Any obstetric complications of these drugs and of epilepsy in general? So they have said that there are a few risks. So the risks are increased for spontaneous miscarriage, antepartum hemorrhage के जो risks है वो थोड़े से बढ़ते हैं, and hypertensive disorders के भी chances बढ़ते हैं. Also there is an increased possibility of induction of labor and cesarean section. ये क्यों हो रहा है? Spontaneous abortions हो सकते हैं because there might be some chromosomal abnormality that is occurring because of sodium valproate या phenytoin जैसे drugs. So the body detects it before time and it spontaneously aborts it. Antepartum hemorrhage can be because of sudden uterine activity that can occur during an episode of seizure. So what happens during epilepsy is that there is पूरे body में electrical discharges. Those electrical discharges also occur in the uterus and there can be, जैसे myoclonic jerks होते हैं of all the striated muscles, वैसे smooth muscles of the uterus can also contract. इसके वजह से sudden contraction की वजह से there can be abruptio placentae that can occur. Also, because of these episodes, if there are multiple seizure episodes, if there are multiple episodes of hypoxia, fetus को भी hypoxia होगा. To compensate for that, the placenta will increase in size. So there will be placentomegaly. Placentomegaly के साथ there can be chances of placenta previa. Basically वो ऐसा extend हो गया, ऐसा size में बढ़ा to compensate for hypoxia कि वो internal os को cover कर गया. So there can be placenta previa as well because of hypoxic episodes. जिसके वजह से antepartum hemorrhage होने के chances ज्यादा है. Again, these can be mistaken for eclampsia and there is an increased chance कि तुम लोग उसको induce कर दोगे. जैसे मैंने बताया था, every seizure in the third trimester is eclampsia until proven otherwise. So they might give the patient magnesium sulfate and they might induce her. And earlier the induction, the worse the Bishop score of the cervix and a higher chance of failure of induction and eventual cesarean section. Hence induction of labor and cesarean section के chances बढ़ते हैं. Obviously फिर preterm delivery तो होना ही है. एंड ग्रोथ रेस्ट्रिक्शन के भी चांसेस है. ग्रोथ रेस्ट्रिक्शन क्यों, मैंने पहले ही बताया, एक तो हाइपोक्सिया है एंड द सेकंड वन इज लो बर्थ वेट बेबी बिकॉज ऑफ प्रीटर्म बर्थ. सो फीटल ग्रोथ रेस्ट्रिक्शन सबसे बड़ा कॉज है हाइपोक्सिया बिकॉज ऑफ दोस सीजर एपिसोड्स. सीजर एपिसोड में द मदर्स रेस्पिरेटरी मसल्स विल कॉन्ट्रैक्ट, देयर विल बी मैटरनल एपनिया, एपनिया इज इनएबिलिटी टू ब्रीथ, देयर विल बी मैटरनल हाइपोक्सिया एंड दैट हाइपोक्सिया विल लीड टू फीटल हाइपोक्सिया. मल्टीपल सच एपिसोड्स विल लीड टू फीटल ग्रोथ रेस्ट्रिक्शन एंड postpartum hemorrhage as well. No differences were seen in gestational diabetes और perinatal death. Perinatal baby के death पे तो इतना कुछ फर्क नहीं पड़ा था. ये तो हुए सिर्फ सीजर में. The women who are consuming anti-epileptic drugs, they will have an even higher chances of induction of labor, fetal growth restriction, and postpartum depression. The fetal growth restriction can also be because of those malformations if the female is consuming something like phenytoin or sodium valproate. Obviously, these things are much higher in women who are receiving polytherapy and cesarean section and everything was increased in them as well. So how do we monitor seizure episodes? You should remember that seizure episodes are triggered by sleep deprivation and stress. So a lot of women are stressed about their careers and everything when they conceive. So that can be a reason why they often have seizures. Also sleep deprivation because of that baby, that gravid uterus, they are unable to sleep well. And इसके वजह से उनका sleep impair होता है. Sleep deprivation also because of the stress of pregnancy, that can be a trigger for epilepsy or seizure episode. Also the compliance, they might be scared कि मेरे drug लेने से मेरे baby को problem होगा, so they might stop taking the drugs खुद से ही. there can be a episode of seizure because of stopping of those drugs themselves, and hence there can be an increased chance because of these risk factors, not by itself. अगर ये सब control में रहा तो there won't be an increase, but if these factors come in, then there is an increased chance that the female will get seizure episodes during pregnancy. And if a female is getting a seizure episode, I would recommend that you admit her at least for 24 hours and get her evaluated well, especially if she has had a fall. If she has had an abdominal fall, then do an ultrasound. Look if there is any abruption, any small abruption or any small hematoma that is formed below before the placenta. So do an ultrasound, monitor her well, and discharge her after 24 hours if there is nothing else that is required of her. How do you monitor the babies? Of course, fetal growth restriction का तो चांस है ही, तो सीरियल ग्रोथ स्कैन्स आर रिक्वायर्ड इंटरवल ग्रोथ मॉनिटरिंग करने के लिए. अगर IUGR है तो you have to deliver them at 37 weeks of gestation. But apart from that, routine antenatal surveillance with NST, cardiotocography is not significant because cardiotocography पे तो कुछ abnormalities आएंगे नहीं. This is a sudden event. एक sudden seizure आ गया, sudden hypoxia हो गया, IUFD हो सकता है. So antenatally CTG करना, NST करना कोई मतलब नहीं है. It is going to be normal only. Fetal heart rate changes. There is because of hypoxia, there is bradycardia and variability भी कम हो जाता है. Beat to beat variability is reduced on cardiotocography, but it cannot predict fetal death. It is a transient change that will be reversed. So even if these changes are coming, वो reverse हो जाएगा once the maternal oxygenation improves after the episode of seizure is gone. So ये सिर्फ during a seizure के problems है due to possible fetal hypoxia. But otherwise, there is not significant change. There is no change in the baseline or accelerations or duration of variations. So there is no evidence of any routine NST का काम कुछ है नहीं. Now these drugs, do you need to take vitamin K alongside it? Vitamin K लेने की जरूरत है क्या? All babies that are born to enzyme inducing drugs. So what are enzyme inducing drugs? So enzyme inducing drugs are carbamazepine, phenytoin, phenobarbital, oxcarbamazepine, topiramate and eslicarbamazepine. So these drugs are enzyme inducing. Enzyme inducing मतलब क्या? कोई भी बॉडी में ड्रग को काम करने के लिए या बॉडी में कोई भी चीज काम करने के लिए देयर आर एंजाइम्स, साइटोक्रोम एंजाइम्स, माइक्रोसोमल एंजाइम्स. those enzymes if they are induced यानी उनका काम अगर बढ़ाया गया, so they will start acting over time. वो लोग overwork करेंगे and they will end up destroying the effect of other drugs. the other body में जो important minerals है उसको जल्दी से खत्म करेगा. they will metabolize it quickly. सो एंजाइम इंड्यूसिंग ये सब जो है वो इंड्यूस करते हैं. सो बेसिकली वो फास्टन करते हैं डिस्ट्रक्शन ऑफ सेवरल थिंग्स इन आवर बॉडी. उसमें से एक है विटामिन के. सो ऑब्वियसली हर बेबी को 1 मिलीग्राम, हम तो 10 मिलीग्राम देते हैं. इंट्रामस्कुलर देना है आफ्टर बर्थ, डेफिनेटली देना है. देयर इज इनसफिशिएंट एडवाइस दो कि रूटीनली मदर को ओरल विटामिन के देना है कि नहीं, या इनसफिशिएंट एडवाइस है कि बेबी को इनसफिशिएंट एडवाइस है कि विटामिन के देना है क्या टू अवॉइड पोस्टपार्टम हेमरेज. इट वोंट कॉज कंप्लीट कोएगुलेशन डिफेक्ट बट इट कैन लीड टू इन द बेबी थोड़ा बहुत विटामिन के का डेफिशिएंसी. और अगर विटामिन के कम हो गया इट विल लीड टू हेमरेजिक डिजीज ऑफ न्यूबॉर्न. हेंस जस्ट अ प्रोफाइलैक्टिक थिंग, नथिंग एल्स. 1 ग्राम का इंट्रामस्कुलर डोज हैज टू बी गिवन आफ्टर बर्थ. When do you terminate them? When do you deliver them? All these patients will have an uncomplicated labor and delivery. Do not do an LSCS unnecessarily. Do it only for obstetric indications. And it is obviously not an indication for planned cesarean section or induction of labor. So you can wait till term. Unless there is fetal growth restriction, then you have to deliver them earlier. But if there is nothing abnormal as such, then only follow your obstetric advices and deliver them at term at 40 weeks. Intrapartum care, intrapartum कुछ करना है. What are the risks and risk factors for seizures in labor in women with epilepsy? Pregnant women should be told that the risk of seizures is fairly low, and especially if I'm giving her adequate analgesia and proper care is given, then if she does not have insomnia, stress, dehydration, unnecessarily patient को nil by mouth मत रखो. Let her keep having fluids. If she's in latent labor, don't keep her in the labor ward where she'll be too stressed about it and she won't be able to sleep. Let her sleep if she's not having pain. If she has pain, pain can be a reason why she is not able to sleep, जिसके वजह से seizure आ सकता है. So for those patients, give them epidural analgesia or give them parenteral anesthesia, analgesia with paracetamol. तो ये सब तुम लोग उसको दे सकते हो. Long acting drugs like clobazam, a rare drug, can be given only if there is a high risk of seizure in the peripartum episode. So if she has a history of seizures in a previous pregnancy after delivery, if she is someone who has had multiple seizure episodes during this current pregnancy, then she can be given something like clobazam in in during labor. Apart from that, you do not need to skip the anti-epileptic dose. If you cannot give this female orally, then if you have to keep her NBM, then you can give her IV, say you can give her parenterally. So seizures in labor can lead to maternal hypoxia because of apnea, because of the respiratory muscles ka problem, and eventually fetal hypoxia and acidosis, which can be because of the uterine hypertonus. Basically, the uterine contraction, smooth muscle contractions जो होते हैं, just like body के muscles होते हैं, uterus के muscles होते हैं, उसके वजह से there can be transient hypoxia. Sleep deprivation and non-intake of IEDs can be the reason, so do not deprive them of those drugs. दे दो उनको drugs time to time दे दो. There is no point of skipping them like you skip metformin or insulin. Don't skip it, you have to give them. Pain, tiredness, stress, and dehydration are factors that can precipitate a seizure, so do not let them have any of these. Pain है तो उसको adequately analgesia दे दो, उसको epidural analgesia दे दो. If she is having excessive vomiting during labor, then उसको parenterally दे दो, but do not skip the dose. And an epidural analgesia, pain relief with an epidural analgesia is a good way to minimize pain and the possibility of her having a seizure. Finally, what is the optimum management? If she still gets an epileptic seizure, then every unit should have a plan कि कैसे manage करना है. It should be immediately managed because उससे maternal and fetal hypoxia हो सकता है and fetal acidosis की वजह से fetal IUFD, intrauterine fetal demise हो सकता है. So to immediately stop seizures, benzodiazepines are the drugs of choice. So any seizure that lasts more than 5 minutes or there is no regaining of consciousness between two episodes of seizure, then we call it status epilepticus. It's a life-threatening medical emergency जिसके वजह से aspiration भी हो सकता है and a female can die of it. So treatment has to be initiated immediately. So first of all, left lateral tilt देना है so that the iotocaval compression is gone, and oxygenation देना है so that those hypoxic episodes which can lead to intrauterine fetal demise are reduced. उसके बाद में मेंटेनेंस ऑफ एयरवे. इफ शी इज नॉट रीगेनिंग कॉन्शियसनेस, देन इंट्यूबेट हर सो दैट हर एयरवे इज एस्टेब्लिश एंड शी डजंट हैव एस्पिरेशन. एयरवे जब तुम लोग एस्टेब्लिश करोगे एंडोट्रैकियल ट्यूब डाल के, मैनुअल वेंटिलेशन, मैकेनिकल वेंटिलेशन पे उसको डाल दो सो दैट हर एयरवे इज सिक्योर्ड एंड इट डजंट कोलैप्स और देयर इज नो एस्पिरेशन फ्रॉम द गैस्ट्रिक कंटेंट्स इनसाइड द लंग्स. आइडियली अगर देना है इंट्रावीनस एक्सेस से, ऑब्वियसली शी इज हैविंग अ सीजर राइट नाउ, एपिलेप्टिक एपिसोड है तो ओरली तो दे नहीं सकते, एस्पिरेट करेगी तो आईवी लोराजेपम देना है. The dose of 4 milligram bolus is given and the dose is 0.1 milligram per kg, but you can remember it as lorazepam 4 mg per kg देना है. Diazepam, if you don't have lorazepam, you can give 10 to 5 to 10 milligram, that can be given intravenously. अगर IV नहीं है एक्सेस, शी इज कन्वर्जिंग, IV लाइंस नहीं मिल रहा है तो रेक्टली भी डाल सकते हो. इट कैन बी रिपीटेड every 15 minutes, but the possibility, the onset of action is going to be much more slower. So the drug of choice for an active seizure or status epilepticus is going to be lorazepam followed by diazepam. अगर उससे भी कंट्रोल नहीं हुआ, then you have to start going for the higher ones, that is phenytoin. फेनिटोइन का डोज जो तुम लोग देते हो वो है 1 ग्राम स्टैट डोज देना है. एंड अगर उससे भी नहीं हुआ तो यू हैव टू गिव हर जनरल एनेस्थीसिया एंड यू हैव टू पैरालाइज हर. दैट इज द लास्ट मोडालिटी. सो अगर स्टेटस एपिलेप्टिकस उसको हो चुका है, द फर्स्ट थिंग दैट यू विल डू इज कॉल फॉर हेल्प. अकेले नहीं मैनेज करना है, अकेला हीरो कोई नहीं बनता है. देन यू हैव टू गिव हर लेफ्ट लैटरल प्लस O2 का पोजीशन देना है उसको विथ मास्क. उसके बाद में उसका एयरवे एस्टेब्लिश करना है, बी इज ब्रीदिंग एस्टेब्लिश करना है एंड सी सर्कुलेशन. सो एयरवे तुम लोग एस्टेब्लिश करोगे बाय पुटिंग एन ईटी ट्यूब, दैट इज एंडोट्रकियल ट्यूब. ब्रीदिंग एस्टेब्लिश करोगे if required by मैकेनिकल वेंटिलेशन एंड सर्कुलेशन बाय एन आईवी लाइन. ये दोनों सबसे इंपॉर्टेंट है, ये इमीडिएटली करना है टू अवॉइड एस्पिरेशन एंड एपनिया. आईवी लाइन से तुम लोग उसको ड्रग्स कौन सा दोगे? पहले लोराजेपम दोगे 4 मिलीग्राम स्टैट डोज विच कैन बी रिपीटेड आफ्टर 10 to 15 मिनट्स. उससे भी अगर कंट्रोल ना हो तो यू विल गिव अ डायाजेपम. डायाजेपम दोगे. उससे भी कंट्रोल अगर नहीं हुआ तो 5 to 10 mg दोगे बाय द वे. और उससे भी कंट्रोल नहीं हुआ देन यू विल गिव हर ऑन फेनिटोइन 1 ग्राम. एंड देन इससे भी कंट्रोल ना हो तो जनरल एनेस्थीसिया देके उसको पैरालाइज एंड सेडेट कर देना है. अपार्ट फ्रॉम दैट ये तो मदर के लिए हो गया. यूट्राइन हाइपरटोनस भी तो है जिसको मुझे देखना है. सो इफ देयर इज यूट्राइन हाइपरटोनस देन गिव अ टोकोलिसिस. टोकोलिसिस ओरली देना है तो निफेडिपिन दे सकते हो, अगर आईवी से देना है तो आइसोक्सुप्रिन, डुआडेलोन ऐसा ड्रग दे सकते हो, रेटोड्रिन दे सकते हो, या फिर द बेस्ट पॉसिबल ड्रग इज अटोसिबान, ये कुछ भी दे सकते हो. इफ द इलेक्ट्रॉनिक फीटल मॉनिटरिंग हैज टू बी स्टार्टेड एंड इफ इट्स स्टिल नॉट एबल टू रिकवर विद इन 5 minutes और द सीजर्स आर रिकरेंट देन एक्सपीडिएट डिलीवरी एंड if not vaginal then cesarean section is to be done. बट बेबी को ऐसे ही जाने मत दो कि तुम लोग कंट्रोल कर रहे थे सीजर और हो गया. जनरल एनेस्थीसिया दे दो, उसको सेडेट कर दो, पैरालाइज कर दो एंड डिलीवर द बेबी. व्हाट आर द मोड्स ऑफ एनेस्थीसिया दैट वी कैन गिव? बहुत ही आसान सा जवाब है जो अपने पास अवेलेबल है, उसमें एंटनॉक्स है विच इज नाइट्रस ऑक्साइड प्लस ऑक्सीजन. व्हाट आर द ड्रग्स दैट यू शुड नॉट बी गिविंग? पेथिडिन इज वन ड्रग दैट यू शुड अवॉइड. And there are few more drugs that you cannot be giving. Those drugs are यहाँ पे दिया है, हाँ, pethidine, ketamine and sevoflurane. These are the drugs that you give usually for normal patients during LSES, but you do not give it to patients who have a higher increased chance of seizure. So severe preeclampsia के भी patients में ये तीन drugs pethidine, ketamine and sevoflurane नहीं देना है. They are known to lower the seizure threshold and can have epilepsy का precipitation. Postpartum period में they have to be continued, all these drugs have to be continued, anti-epileptic drugs have to be continued. They have to be told that there is a chance कि उसको seizure का threshold बढ़ सकता है, and अगर उसको nausea vomiting है post delivery then she can be given parenterally all these anti-epileptic drugs. Sleep deprivation avoid करना है, तो उसके साथ एक हेल्प रखनी है so that she can help with the feeding of the baby and the baby doesn't keep her at night. If the baby is keeping her up at night, that can be a reason that she is having all those seizure episodes. So give her anxiolytic to her and ensure that the baby is being well fed by some helper. Any need to modify the dose? Then if it was increased during pregnancy, then just review it within the first 10 days to avoid postpartum toxicity. So देखो 10 दिन के बाद अगर चाहिए तो pre-conceptional dose पे you can bring it back. What are the effects that the newborn can have? So the rates of transfer through the placenta and breast milk vary. A few of the older anti-epileptic drugs like phenobarb, carbamazepine, and phenytoin, and newer drugs like lamotrigine, oxcarbamazepine, and topiramate have an umbilical cord of umbilical cord मतलब have a fetal cord. Basically there is free transfer. वो umbilical cord का जो levels है और मदर का लेवल से दे आर द सेम. सो बेबी को ये ड्रग्स जाते हैं, फिनोबार, कार्बामाजेपिन, लैमोट्रिजिन, ऑक्सकार्बामाजेपिन एंड टोपिरामेट, जिसके वजह से these babies can have lethargy, difficulty in feeding, basically withdrawal syndrome जैसा हो सकता है, excessive sedation and withdrawal symptoms with inconsolable crying. So these babies will probably need to be kept in the ICU so that they do not have complete respiratory arrest or they stop feeding completely, जिसकी वजह से hypoglycemia and baby को ही seizure हो जाए. तो ये नहीं करना है. So what is the ideal बेबी टू मदर का रेशियो? दैट इज 0.6. सो अगर मदर में 1 ग्राम है ब्लड में ड्रग, तो बेबी में 0.6 होना चाहिए. इट इज नेवर सपोज टू बी 1. द रेशियो इज नेवर सपोज टू बी 1. द रेशियो इज बेबी टू मदर इज 0.6. दैट इज व्हाट इज आइडियल. So lamotrigine is a good drug on that part. Levetiracetam is an okayish drug. Even topiramate is post delivery okayish ही है, but compared to सोडियम वैल्प्रोवेट एंड ऑल दीज ड्रग्स जो है उनका काफी कम है ट्रांसफर थ्रू द ब्रेस्ट मिल्क. सो सोडियम वैल्प्रोवेट दो इट इज नॉट एडवाइजेबल, बट पोस्ट डिलीवरी न्यूरल ट्यूब डिफेक्ट का तो कोई प्रॉब्लम नहीं है तो दे सकते हैं. कॉग्निटिव डिफेक्ट इज अ प्रॉब्लम. कार्बामाजेपिन एंड फेनिटोइन कैन बी गिवन. लैमोट्रिजिन, लेवेटिरासेटम कैन accumulate more in the baby, but they are not known to have any side effects as such. Breastfeedings you have to continue. It has a much bigger picture में, it has a much bigger side फायदा है बेबी का, तो देना ही है. And babies who are breastfed, they had a much better psychomotor neurodevelopment, तो उसका अच्छा हुआ था at 6 to 18 months. Last topic सबसे important कि contraception क्या देना है. Copper T is the best possible contraceptive device, followed by LNG IUD, that is Mirena, and then DMPA. So these are the three best ways. Whereas ये जो drugs है carbamazepine, all these enzyme inducing drugs, again the same suspects, they are known to cause failure of few hormonal contraceptives. Those few hormonal contraceptives especially are estrogen related. तो oral combined contraceptive pills जो है, oral combined hormonal contraceptive pills, even progesterone only pills, transdermal patches, vaginal rings, ये सब जो है, अगर ये कार्बामाजेपिन, फेनिटोइन इनके सब के साथ लेंगे सो उसका एक्शन नहीं आने वाला है. दे विल इनहिबिट द एक्शन ऑफ दीज ड्रग्स. सो द ओनली सेफ ड्रग्स that you can take, the safest contraception is going to be copper T. Hence, women who are taking enzyme-inducing AEDs have to be told that a copper T, which is a non-hormonal contraceptive device, is the best possible choice. And even emergency contraception, अगर IPL कुछ ले रहे हैं तो levonorgestrel and ulipristal is hopeless. जो IPL लेते हैं pointless है. उनमें भी you have to give copper T only. So the expected failure rate of oral contraception is 3 times higher in women who are taking enzyme-inducing IADs. Not all the anti-epileptic drugs, but only the ones that induce the enzymes. कौन से वाले हैं वो? Carbamazepine, phenytoin, phenobarb, oxcarbamazepine and topiramate. So these are the main ones. So उनमें chances बहुत ज़्यादा है. So the levels of ethinyl estradiol and levonorgestrel were reduced in patients who were consuming all these drugs. Whereas जिसमें कोई भी फर्क नहीं था वो था लेवेटिरासिटम, गाबापेंटीन, जोनासिमाइड एंड टियागाबिन. उसमें से जो कॉमनली हम देते हैं इज लेवेटिरासिटम. Topiramate in therapeutic doses below 200 does not interact with oral contraceptive drugs. Higher doses of topiramate, though, that is between 200 to 800, may modestly increase the clearance. So topiramate is a selective one. The best one, though, is going to be levetiracetam. So in women who are taking these enzyme inducers and still wish to take their oral contraceptive pills, then the dose of estrogen has to be increased to 50 मिलीग्राम. अभी हम लोग लो डोज ईस्ट्रोजन देते हैं जिसमें 30 to 50 मिलीग्राम ही रहता है. इनफैक्ट 30 रहता है, आज तो 15 भी आने लग गया है. इनमें यू हैव टू टेक इट टू 70, बट इसके वजह से द रिस्क ऑफ डीवीटी एंड ऑल लिवर फेलियर विल बी हाईली इंक्रीज. द रिस्क ऑफ थ्रोम्बोसिस स्पेशली इन पोस्टपार्टम वुमेन 6 वीक्स तक तो ये कॉन्ट्राइंडिकेटेड है. ओरल कॉन्ट्रासेप्टिव पिल्स कॉन्ट्राइंडिकेटेड 6 वीक्स आफ्टर डिलीवरी. उसके बाद भी अगर देना है तो डोज बढ़ा के देना पड़ेगा, विच इज नॉट आइडियल. ऑल्सो द पिल फ्री इंटरवल, मतलब हम लोग 3 वीक्स देते हैं और 1 वीक नहीं देते हैं ना. सो वो 7 डेज, 1 वीक की जगह ओनली 4 डेज करना है. सो 4 डेज ही ड्रग्स नहीं लेना है, फिर से रिस्टार्ट करना है क्योंकि ये जल्दी बॉडी से क्लियर हो रहा है. 7 डेज तक वो कॉन्ट्रासेप्टिव एक्शन नहीं रहेगा. दैट 1 वीक इन विच वी आस्क द फीमेल फ्रॉम टेकिंग नथिंग, उसमें हम लोग आयरन के पिल्स देते हैं, उसमें उनको 7 डेज की जगह 4 डेज ही करेंगे. बॉडी से वो ड्रग्स बहुत जल्दी निकलने वाले हैं. Barrier contraception is a good alternative to it. It is not the best contraceptive though, so it should be taken in addition to all these drugs. For emergency contraception, only and only copper T is the one. There is no other drug that can be taken. And oral contraceptives can also increase the excretion of a few drugs. So though lamotrigine is not one of them, oral contraceptive use has been associated with a 20 to 75% decrease in lamotrigine levels. So you have to also understand that a few drugs, ulta bhi action aa sakta hai. Just like all those epileptic drugs were inhibiting OC pills can also inhibit a few drugs. उसमें से सबसे बड़ा है lamotrigine. Lamotrigine is a very good drug. We have learned in pregnancy, but it can have a poor effect if it is taken with oral contraceptive pills, in which the patient will have eventually seizures आएंगे. So falls in level of lamotrigine are much more likely to occur in women who are taking OC pills. So what are the recommended ones? There is something called as UKMEC. UKMEC is UK medical eligibility criteria. So UKMEC 1 is the best possible drug and you can take it, whereas 4 is something that is contraindicated. So enzyme inducing अगर drugs ले रहे हैं, which are carbamazepine, oxcarbamazepine, phenobarb, phenytoin and topiramate. अगर ये ले, topiramate also more than 200 mg अगर ले रहे हैं, this is 3, so basically you have to avoid it. Progesterone pill to be avoided. Progesterone implant, norplant can be taken, but the best one is going to be DMPA, copper T and LNG Mirena. Whereas in patients who are taking non-enzyme inducing drugs like lamotrigine, यहाँ पे दिया हुआ है benzodiazepine, gabapentin, lacosamide, levetiracetam, sodium valproate, ये सब जो ड्रग्स है which are the safest drugs, उसमें तुम लोग कुछ भी दे सकते हो, कोई प्रॉब्लम नहीं है. Whereas एक स्पेशल ड्रग लैमोट्रिजिन में सिर्फ तुम्हें कंबाइंड ओरल कॉन्ट्रासेप्टिव नहीं देना है, बाकी सब कुछ दे सकते हो. So that is it for today's lecture. To brief you all about the long lecture, the three safest drugs in pregnancy, anti-epileptic drugs that you can take is lamotrigine, carbamazepine and levetiracetam. उसमें भी जो carbamazepine लेना है उसको डोज less than 400 milligram लेना है and lamotrigine less than 300 milligram per day लेना है. The drugs that are absolutely contraindicated include sodium valproate as the worst possible drug for teratogenicity point of view, followed by phenytoin, topiramate above 200 mg and phenobarbital. ये सब जो है carbapenem, ये सब avoid करने हैं. Pregnancy में क्या problem आ सकता है? What is the problem that pregnancy can face? So how does pregnancy affect seizures? The risks are not generally increased except if there are other contributing factors like loss of sleep, pain or stress. These can precipitate seizures, but if these are not present, then the female will not have, 66% of the females won't have any deterioration of their seizure levels. Apart from that, how does it affect the baby? Because of episodes of seizures, there is going to be apnea. The mother is not going to be able to breathe during that seizure episode. This will lead to hypoxia, leading to fetal hypoxia. This, if is occurring multiple times recurrently, then there will be fetal growth restriction. Fetal growth restriction के chances बहुत ज़्यादा है. There is a chance that you might need to deliver the baby before time because you might just think of it as eclampsia, so that is one high risk. Apart from that, intrapartum उसको continue करना है anti-epileptic drug. पोस्ट डिलीवरी कॉन्ट्रासेप्शन का अगर बात करेंगे तो ओरल कॉन्ट्रासेप्टिव पिल्स अवॉइड करो. द बेस्ट ड्रग्स दैट यू कैन गिव इज डीएमपीए, मायरेना एंड कॉपर टी. इमरजेंसी कॉन्ट्रासेप्शन के लिए द ओनली ड्रग दैट यू कैन गिव इज कॉपर टी. एंड that is it for this session. I hope this session, a slightly longer one, is going to help you understand and be able to treat patients with epilepsy in pregnancy much better than you already did. You don't really need a neurologist at every point of care. You need consultations, but you don't need it on an everyday basis. You can manage it on your own as an obstetrician. Yes, I have seen a lot of females getting levetiracetam जिसका बहुत ही कम है एविडेंस लेवल. अभी बढ़ गया है थोड़ा, बट स्टिल इट इज नॉट एज गुड एज लैमोट्रिजिन जैसे चीजें. But we still give it. It's a safe drug that can be given. Apart from that, I hope you all have understood everything that we have learned today from this guideline. If you all have any doubts, please reach out to us on Conceptual OBG. Until next week, when I bring you yet another guideline, this is a goodbye from me. So goodbye, take care, and signing off, Dr. Aditya.